Welcome back to Bring It Home, where we take issues of homeland security and bring them home to you. I'm very pleased to be joined today by Dr. Scott Lillibridge, who's the director of the National Center for Emergency Preparedness and Response here at Texas A&M. Scott, thanks a lot for being with us.
Dave, it's good to be here.
Tell me, what is the Center for Emergency Preparedness and Response? What is this thing you direct?
Well, the National Center for Emergency Medical Preparedness and Response is a new entity at Texas A&M. It brings all the capacities that we've had in emergency management, EMS, and first responder, and joins those with the health sciences to create a hybrid activity that's logistically supported, yet has all the best expertise in health and medical.
And these are major resources. When you talk emergency management, we're talking about the TEACS, a facility that trains 70,000 responders a year here. You're talking about a major medical center, a major capability that you're bringing together.
We're adding a medical and public health component to an existing capacity that we have that's already world-class. And this adds another slice of the pizza, so we essentially have the whole the whole training capacity here at
Big
Texas
organization here in College Station, but you also have some facilities in Houston.
We have, in the heart of the Texas Medical Center, have one of our outlying teaching, training, and clinical sites that we have, and our administrative hubs right here at College Station, linked with really at the engineering and health science level.
Scott, I want to talk for a minute about your personal background, because you are such a great example of what it means to bring together these different backgrounds, different capabilities, and to bring them together in a new way. Would you give us a little background, your medical background, and then your government background?
Dave, you're kind. Wish my mother was here to hear this, but let me kind of just talk about the philosophy of how I grew up. I've had a long medical and public health career in different agencies, and one of the most important things that I did is made the jump from treating patients one at a time in emergencies when I was director of chief of emergency medicine to begin look at taking care of populations at a time as I began to work in war zones, particularly civil war zones around the world, natural disasters and so forth. Then after 9/11, these programs in the United States began to get big as we began to get concerned about developing that capacity for internal response.
Who did you work with overseas?
I've worked overseas with many organizations, Red Cross, International Rescue Committee, the United Nations, WHO, a number of Department of Defense, the State Department. And
then within our government, you've focused on healthcare writ large within our government.
You know, when I came to the Centers for Disease Control as a relatively young professional, and I went through the Epidemic Intelligence Service, and everybody has a beat. And my beat was kind of emergency health services. And we began to provide assistance to health departments imperiled by disaster in the United States, and then began to work overseas on providing technical response to agencies taking care of refugees.
You know, Scott, 9/11 really was a galvanizing moment in many respects. People look back now and they say, "Oh, politically we may have overreacted. It was had a military aspect to it." But in this respect, healthcare, public health, medical capabilities, it really was a galvanizing moment. Explain to us why and how, would you?
A number of interesting things happened. Remember that the movement to put money in the public health infrastructure development really started about fiscal year 1999 with the Bioterrorism Preparedness and Response Program.
Which was terrorist focused as well before 9/11.
Absolutely, and that was a program that I started at CDC. It had about $150 million. That was big money in those days. And its thrust was to build up surveillance laboratory training at state health departments so they could be ready for
By surveillance, you mean being able to see nationwide where are we having a lot of an unusual activity, and therefore I track that I've got an outbreak.
Look at those unusual cases. It was to enhance disease tracking. So that started in earnest. After 9/11, the supplemental that came in brought $3.5 billion in the first wave into the public health and medical infrastructure.
So from 150 million to 300 billion
overnight.
Overnight.
So that by the end of that year, we had nearly $1 to $2 billion moving into health departments to revitalize labs, enhance disease tracking, add disease detectives, begin to engage in training, exercises, and so forth, so that by the end of last year, after we have about 8-9 years in this project, we have significant capacities that we didn't have 8 or 9 years ago.
Are you satisfied with the way the nation's moving in this field?
You know, I think we've done some good things, but I think it's now time to begin to deal with the fact that the infrastructure that we want to galvanize in an acute emergency largely resides in the private and academic sector. Let me give you a case in point. When we had to deal with Katrina, we had literally thousands of people that needed things like triage, evacuation, sheltering, hospitalization, and so forth, things that are in the National Disaster Medical System, which is woefully underfunded. That component needs to be developed as vigorously as we develop the public health preparedness
There really
side.
are no national beds. There are no national doctors. There are no national resources to send, are there?
There is no hospital standing empty like a fire department ready to roll. We need to borrow and co-opt those expertise and those talents and equipment and so forth. Let me give you a case in point. We're putting out nearly $600–700 million to health departments for preparedness activities. In contrast, the National Disaster Medical System, which is the body that puts disaster teams, field hospitals, and so forth, runs in about $40 million a year.
Tiny for a national system.
Huge imbalance. You're not going to galvanize the private sector, emergency health services, by depending on volunteer teams to be federalized.
Now, how will your center and Texas A&M, how are they impacting that? How are they trying to address those problems?
Well, a little at a time. First of all, we're a state agency and a state university, state-sponsored university. So here at Texas A&M, our approach really is to begin building in Texas our version of a Texas disaster medical system of hospitals, public health capacity, and disaster medical teams here at the state level to begin put some resources in the game at the state level.
So while you might not be able to go to the federal government and say, hey, where are your hospitals, you can go within the state of Texas, 900 miles by 1,100 miles, and borrow and share resources.
Exactly. The federal government works best if it can augment, support, fund, and assist. It doesn't work so well in the response arena if it comes to just simply take over and stay.
And so what your center will do is teaching, coordination, teaching doctors, who exactly, and how will you address that?
Exactly. Our primary audience is the health and medical audience, or public health and medical audience of hospitals, clinics, public health departments. And the things that we do are teaching, training, research, service activities. On the response side, we've spent our time developing a Texas disaster medical system where we can all work and galvanize existing talent. And the academic side, we teach classes in the School of Public Health, School of Medicine, and we provide an oasis for fellowships and a way to really engage the other academic health centers in Texas, including those from UT and North Texas and so forth.
Scott, 30 seconds left. We also have the advantage, if you will, that Texas has seen Katrina, Texas has seen Rita, Texas has seen Ike, and we are galvanized now in this area, aren't we?
We are. We learned a couple things. One, in the recent response to Hurricane Ike, we realized in the health and medical arena, we cannot depend on the federal government to come here and take care of our business. Texas is too big, the problems are too acute, stretch from the border all the way to the city of Houston.
I'm glad you're working on it. I'm glad your center's working on it. We've been with Dr. Scott Lillibridge, who is the director of the National Center for Emergency Preparedness and Response here at Texas A&M, and we have been here on Bring It Home. Join us for more as you learn about Homeland Security and national security and how we bring these issues home to you.